so our next presenter is Dr. Colin Lowe. And his mentor is my old colleague, Dr. Peter Wang. Hi, Peter, if you're there somewhere. So Colin Lowe is going to talk about principles of sodium management. Now, Colin, if you can get this right and make everyone understand sodium management, you will be doing particularly well, because I still don't really understand it. So I'm looking forward to it.
Hi, Kate. Warmest greetings. I'm very happy to see you again.
Oh, hey, Peter.
Yeah. So it's really wonderful to see you again, and we'll touch base more privately.
Okay.
Yeah.
All right, Colin, are you ready there? Can't hear you, Colin. Wait a minute. You're going to have to unmute yourself.
Yeah, Colin, there you go.
Okay, there you go. You'll need to put, yeah, that's it. Great. You ready?
Okay. Thank you, Dr. Drummond and Dr. Huang. My name is Colin, and I'm presenting on sodium management in the neurosurgery patient today. So why this topic? Because I think it's very important at the junior resident level. One of the most common medical issues affecting the neurosurgical patient is actually sodium disturbances. And also because I feel that the perioperative management of a neurosurgical patient is just as important as the intraoperative technical aspects. And that's what makes our patient go home happily and early. So the learning objectives for this set of slides, I hope that everyone will be able to recognize the common sodium pathologies affecting the neurosurgical patient. And I hope that to help you guys to be able to identify the various assessments needed to evaluate for sodium disturbances. And I hope that you guys will be able to be aware of the treatment options available for the various sodium disturbances. So this is a busy slide, but let's just go through each of them one by one. So this is a simplified hyponatremia algorithm. So first, to prove hyponatremia, we need a sodium of less than 135 millimoles per liter. And subsequently, we divide them into symptomatic or asymptomatic patients. In symptomatic patients who present with confusion, seizure, coma, or obtundation, we usually just go straight to treating them with 3% hypertonic saline till the symptoms resolve, taking care not to exceed beyond 6 to 8 millimoles per liter per day. In patients who are relatively asymptomatic or have only mild symptoms, like headache or giddiness, then we need to do further evaluation before we start treatment. So we first evaluate them by determining their serum osmolality. And if their serum osmolality is normal, then we group this bunch of patients into isotonic hyponatremia, or what we call pseudo-hyponatremia. In these patients, you need to consider hyperproteinuria or hyperlipidemia. And these patients are, for example, multiple myeloma can lead to increased protein, or familial hyperlipidemia may lead to increased lipids in the blood, which replace sodium as the dominant solute in the bloodstream. In our next set of patients, we have the hypotonic hyponatremia. This is part of some of our neurosurgical patients get this. And so after you determine hypotonic hyponatremia with a low serum osmolality, we need to assess their volume status next. And we do this by examining their jugular venous pressure, their orthostatic blood pressure, and their skin turgor or their mucous membrane. And if you establish them to be hypovolemia, you next look at their urine sodium. If their urine sodium is high, above 20 millimoles per liter, you consider renal losses like drugs or something what we call cerebral salt wasting, which I'll come to later. If their urine sodium is low, that's when you consider other causes like vomiting, diarrhea, or insufficient intake. The treatment for both conditions are also isotonic saline, but it's still important to differentiate them so you can reverse the underlying cause. In the next subset of patients with hypotonic hyponatremia, we have patients who are euvolemic, which means that their volume status is pretty normal. The important one for neurosurgical patients is actually patients with a high urine osmolality, and this is more than 100 milliosmol per kilo. And the important thing to look out for here is syndrome of inappropriate antidiuretic hormone patients, which are very common in neurosurgical patients. The other smaller subset is actually patients with primary polydipsia or low solute intake, in which case their urine osmolality will be low. The treatment for both conditions is fluid restriction. The next subset for hypotonic hyponatremia are patients with hypervolemia. This is predominantly a medical cause, so I will not go into much detail, But the treatment for these patients are actually fluid and sodium restriction along with diuresis or dialysis. And so for patients with a hypertonic hyponatremia, which means they have a high serum osmolality, you need to assess them for hyperglycemia and the use of mannitol or radio contrast media. Again, this hyperglycemia or mannitol can replace sodium as a solute in the bloodstream and cause your hypertonic hyponatremia. So let's just go to a few cases that I have for today. So case number 1 is a 78-year-old female who slipped and fell at home, and the CT brain shows bilateral frontal contusions. This is currently the day 3 of admission, and you have reviewed the patient and assessed her to be euvolemic on assessment. However, her serum sodium is low at 123, her serum osmolality is low at 257, her urine osmolality is high at 562, and her urine sodium is also high. Her thyroid function test and 8 AM cortisol are both normal because we're trying to exclude hypocortisolism and hypothyroidism. So in this case, we have a diagnosis of hyponatremia because the sodium is 123. She's relatively asymptomatic, and she's also hypotonic hyponatremia because the serum osmolality is low. We have evaluated her to be euvolemic, and her urine osmolality is 562, which is high. So in this case, her diagnosis is actually SIADH, and the treatment here is fluid restriction. So what is the etiology of SIADH? So any intracranial insult can cause release of ADH from the brain. So there's a theory that this is mainly evolutional, because in the past, if you have a traumatic brain injury during the hunter-gatherer times, this bunch of people who have TBI might not be able to hunt for food or water. And in this case, the ADH response to reabsorb free water is actually, it helps to conserve water in the body and helps survival. So ADH acts on the collecting tubules, the V2 receptors of the collecting tubules to reabsorb water. So then the question comes, why do these people have euvolemia and not hypervolemia if you say that they reabsorb more water? So you have to go back to the pathophysiology of SIADH. So you start off with the inappropriate ADH release, which causes more free water reabsorption in the collecting ducts. This actually correspondingly leads to an increase in the intravascular volume. And when the intravascular volume goes up, it leads to a secondary natriuresis mediated by atrial natriuretic peptide, because there's increased cardiac atrial filling. And subsequently, this leads to a disproportionate loss of sodium compared to free water due to the secondary natriuresis. And therefore, the patient gets euvolemic hyponatremia, and their urine will be more concentrated, which leads to a higher urine osmolality. The workup of SIADH is very simple. So we first assess the patient's fluid status, including the intake-output charts for the last few days, because that's the most important, is the clinical status of the patient. Secondly, we establish the likely etiology. Is this poor oral intake, or is this likely to be caused by secondary things like SIADH? And then we do the patient's labs, so the renal panel, the random glucose, because you want to correct for any pseudo-hyponatremia, and you also take the urine osmolality paired with this patient's urine osmolality and the urine sodium, along with the cortisol and thyroid function test to exclude other secondary causes. And the treatment of SIADH is very simple. It's fluid restriction is the key. In our institution, we do use salt tablets as an adjunct to help to bring up the sodium a little bit faster. And also you can consider the use of hypertonic saline with an ICU or endocrine consult if needed. In the literature, there's also use of vaptans and the macrocycline. The vaptans are a class of drugs which directly act on the V2 receptors in the collecting tubules to block it and prevent the action of ADH. But we don't really use it in the Singapore context. The next important thing to do for the treatment is monitoring. So you monitor their strict intake output to make sure that they're properly fluid restricted, and you give them a high protein, high salt diet to try to increase the amount of solutes in their bloodstream. And usually you will trend their sodium daily until it uptrends nicely, and then you loosen the fluid restriction along the way as the SIADH response improves. Case number 2 is a fairly similar history. So 78-year-old female who fell and had bilateral frontal contusions. This time when you examine her, you see that she's quite dry. Her mucous membrane is dry. She has poor skin turgor. And if you look at her charts, she's refusing her meals and not drinking much fluids. So her serum sodium is low. Her serum osmolality is also low. Her urine osmolality is high, but her urine sodium in this case is low, is 18. So if you go back to the algorithm, we established that she has hyponatremia and it's relatively mild, and it's a hypotonic hyponatremia because the serum osmo is low. In this case, compared to the other one, she is hypovolemic and her urine sodium is actually low at less than 20 millimoles per liter. And this is consistent with her intake output chart of insufficient oral intake. So the treatment for her is isotonic saline and encouraging her to eat and drink more. Case number 3, again, a similar history. And this case, the patient is also dry, skin poor turgor, and a mucous membrane is dry. Her serum sodium is also low, and her serum osmolality is low, which is hypotonic hyponatremia. Urine osmo is high, and the urine sodium in this case, compared to case number 2, it's much higher than case number 2. If you look at her intake output charts, she has passed over 2 liters of urine over the last 12 hours, and she's negative 3 liters over the last 24 hours. So this is a case of cerebral salt wasting because it's a hypotonic hyponatremia. She's hypovolemic, but in this case, her urine sodium is high, which means that she's actually losing both sodium and water in her urine. And the treatment for her is isotonic saline. A little bit more about cerebral salt wasting. The pathophysiology of cerebral salt wasting is the insult to the brain, which causes the release of brain natriuretic peptide. So after the release of the brain natriuretic peptide from brain injury, the BNP leads to increased glomerular filtration rate and decreased renin, angiotensin, aldosterone system. And both of these leads to increased natriuresis and diuresis, and this results in an overall hypovolemia and hyponatremia. The treatment of this is just by replacing fluid losses in the urine 1-for-1 with isotonic saline, and to continue this treatment until the underlying insult resolves, usually when the brain injury recovers. So currently there's no direct pharmacological modality of which we can block the release of BNP. Just one slide on severe hyponatremia. So the classical signs and symptoms are seizure, confusion, obtundation, coma, or respiratory distress. And usually patients with these signs and symptoms usually have a sodium of less than 125. The treatment is stat administration even before investigation with 3% hypertonic saline, and is usually enough to just increase their sodium by 2 to 3 millimoles per liter, and this allows patients to cross the symptomatic threshold. So again, another caution, do not correct the sodium by more than 6 to 8 millimoles per liter over 20, because of the risk of osmotic demyelination syndrome, which is in the past used to be called central pontine myelosis. Case number 4 now. So it's a completely new case. It's a 48-year-old female with a non-functioning pituitary macroadenoma. This is her day 1 of her post-op of her transsphenoidal endoscopic resection. She has high urine output over the last 2 hours of 250 mils and 270 mils respectively. Her serum sodium is high at 147. Her serum osmolality is high at 313. And her urine osmolality is very low, is below the reference value, and her urine sodium is actually pretty normal. A diagnosis here is diabetes insipidus. Let me explain to you why. In diabetes insipidus, usually the diagnosis, you need a high urine output, usually more than 200 mils per hour over 2 consecutive hours. You need a diagnosis of hyponatremia, 145, which she fulfills. You also need a diagnosis of hyperosmolality, which she fulfills. And you also need, the key thing here is that you need a urine osmolality which is lower than her serum osmolality, which indicates a failure of appropriate water reabsorption response at the collecting tubules. Only then can you prove a diagnosis of diabetes insipidus. In this case, she has hyponatremia, is hypertonic hyponatremia, and her urine osmolality is much lower than her serum osmolality, and so the diagnosis is diabetes insipidus. The differential diagnosis for a patient with high urine output is actually post-stress or post-surgery fluid mobilization. After they're extubated, they do get some fluid mobilization, but these patients usually have a normal tonic, normal natremia, and the urine osmolality is usually proportional to their serum osmolality. The next differential diagnosis is psychogenic polydipsia, but these patients with high urine output usually also has a hyponatremia. So the treatment for diabetes insipidus is drink to thirst. So most of our post-pituitary surgery patients, they are usually alert and able to drink to thirst, then they should do so. However, in some patients with very severe brain injury and pituitary damage, they might be completely obtunded and with no thirst response. In this case, you might need some desmopressin to augment their diabetes insipidus. So just some differences between vasopressin and desmopressin. So vasopressin is the intrinsic peptide hormone produced by the posterior pituitary gland, and desmopressin is actually the synthetic version. They did some deamination and some and changed the arginine at the 8th position. So the action of vasopressin is actually both a vasoconstrictor, as the name suggests, and also prevents the water and also helps in the water reabsorption. However, desmopressin is a selective V2 receptor agonist, so it doesn't give you any vasoconstrictive properties. The vasopressin half-life is much shorter than desmopressin half-life. So desmopressin, you can just give a bolus dosing, whereas vasopressin usually requires a continuous infusion. And vasopressin is more limited in its modes of administration. You can usually only give it intravenous or subcutaneous, whereas desmopressin, you have other routes like oral or intranasal, which we use quite commonly in our center. So case number 5, this is a 48-year-old female. She has the same surgery. In this case, her urine output was 250 mils and 270 mils over the last 2 hours. Her serum sodium is 147. Her serum osmo is 313. Her urine osmo is 352, and her urine sodium is 21. So in this case, this is post-surgery fluid mobilization because her urine osmo is fairly similar to the urine with the serum osmo. So she is actually still concentrating her urine appropriately. So if you see here, she only has high urine output, whereas actually her sodium, actually I got the values wrong. I meant to put that her serum sodium is actually normal and her serum osmo is actually normal, together with a normal urine osmolality. So this is actually just post-surgery fluid mobilization. So in a lot of the pituitary patients, most of the high urine output usually is post-surgery fluid mobilization rather than diabetes insipidus. But it's very important to look out for diabetes insipidus because it can potentially lead to morbidity and mortality. So in summary, the 3 most important sodium disturbances in a neurosurgical patient, number 1 is SIADH, and this is classically a euvolemic hypotonic hyponatremia with a high urine osmolality. In mild cases, the treatment for this is fluid restriction, and in severe cases, we use 3% hypertonic saline. The next important sodium disturbance is cerebral salt wasting, and in these patients, they get a hypovolemic hypotonic hyponatremia with high urine sodium and high urine output. And in this case, the definitive treatment is isotonic saline replacement 1:1 ratio. And the third most important sodium disturbance is diabetes insipidus, in which you will have high urine output, a hypertonic hyponatremia, disproportionately low urine osmolality. And the treatment for them is to drink to thirst. And if they are unable to, then compensate them with desmopressin. And the 2 things that you need to look out for our patient population also is the other masking conditions like poor oral intake or GI losses, which can lead to hyponatremia. And in high urine output patients, you have to exclude, even though you have to exclude DI, most of the times it's actually post-surgery mobilization. Any questions?
Thanks, Colin. That was fantastic. You had your most important point, I think, on your first or second slide, where you talked about how we really need to pay attention to all of the non-operative things in the management of our patient to keep them alive. And I think any idiot can learn how to operate, I think, but learning how to actually care for your patients and all the small details, the sodium, the temperature, you know, the doses of the drugs. Have you started the right drugs? Have you stopped the drugs the patient doesn't need? Are they getting Are the physios getting them up? Is their chest physio being done? All of those things. They're the things that will actually make your patients do well. And if you think that it's not real, in my hospital, within the last 10 days, a patient has had severe unrecognized diabetes insipidus, which, going back to Jensen's talk, everyone wrote down the numbers very well. Oh, there's a lot of urine here. Oh, this. But no one predicted the consequences of what they saw to severe detriment of the patient. So it's actually, those two talks go together beautifully. And, you know, that attention to those details is so important. Now, have we got any questions? Oh, we got an excellent lecture from Jorge Salazar. Have we got any questions for Colin? Because he's the man. Not everyone understands this sodium stuff, so he is the man. No, Peter, do you have any comments?
I think they need to take some time just to digest that flow chart and maybe take a picture of it and store it in your phone. I don't know, maybe if Colin can. Are these lectures being archived, or can the participants access these lectures on YouTube or anything?
Yes, all the lectures. Yes, all the lectures are on the Neurosurgical TV YouTube channel. I'll put
great.
I'll put the address in the chat.
Yeah, so I think just encourage all of you to just take a picture of the flow chart and look at it and study it and carry it around with you when you next see a patient with a sodium abnormality. The other thing is just to look at your daily fluid input output charts and weigh your patients daily as well if you're not sure, because often the patient's body weight will give you an idea, you know, whether they are hyper, hypo, or euvolemic. And if in any doubt, just call your endocrine or general medical colleagues for help.
So I think we've had 3 wonderful talks. Felicia has reminded us that everything in neurosurgery is about positioning and access. And if you don't set yourself up properly for that, then the whole case is going to go badly. Jensen's reminded us that we need to evaluate our patients, but not only evaluate them, think about what's going to happen next and act upon it, which is an incredibly important skill. And Colin has reminded us that the devil is in the detail for the care of our patients. Everyone can learn how to make the cut and take the tumour out, but the care of the patient and the detail of that is incredibly important. So I'd just like to thank our 3 speakers. Thank John Bennett for putting this all, making it happen. Thank our 2 mentors. And Wan Chu Sao, who's hiding there in the background from the Asian Australasian Society, who's put this all together. And thank you everyone for participating. We are going to continue with these neurosurgery boot camps. We'll broaden them out a bit. I'll be making some of my residents do some presentations. So we'll continue with them because I think they're incredibly valuable. So thank you, everybody.
Thank you, everybody.
Thank you very much, Kate.
Thank you.
Bye-bye.
Safe. God bless.
Bye.
Thank you very much.